Please. Thank you. Good afternoon to all. So happy to see you again. As ma'am said, today we are going to learn about the management part of part 2, that is on opioids. Last week we have learned about NSAID adjuvants and weak opioids. Today we have Dr. Sunilkumar. He's a palliative care physician. And he did his fellowship in palliative medicine from Amrita Institute of Medical Science, and he did his MSc palliative care from Cardiff University. He has more than 19 years of experience in palliative care. He is working as an additional director of Trivandrum Institute of Palliative Science. So he is a well-versed person in this field. We are very lucky to have you here, sir. Thank you, sir, and over to you.
Thank you, Shiva, and good afternoon, everybody. So we will discuss regarding the strong opioids or opioids for moderate to severe pain. You already had a discussion on opioids for mild to moderate pain in the previous class. And is it visible?
Yes, sir.
Okay. So this is what we are going to cover today. What are the commonly used opioids? What are the mechanism of action of opioids? And the practical aspects is one of the important things, because when you use opioids, you will have many doubts. So we'll discuss some of those. And what are the adverse effects of opioids, which we need to understand. And again, when we prescribe medication, many patients may not take it properly, and maybe because of many reasons, but one of the reasons is the price of the medicine. So if you prescribe a costly medication, the poor patient may not be able to purchase it, so that they will have poor symptom control. They will come and tell you that I don't have proper symptom control, and then you will start increasing the medication rather than finding out the reason behind that. So it is important to know the price of opioids also. So all of you know the WHO analysis ladder, which has 3 steps, and from the second step onwards we have opioids. In the second step, we have opioids for mild to moderate pain, which includes tramadol, tapentadol, codeine, dextropropoxyphene. Those are the opioids available in India. And in the third step, we have opioids for moderate to severe pain. So can anybody tell me what are the opioids for moderate to severe pain? Anybody please unmute and speak.
Sir, good afternoon, sir.
Yeah.
Sir, for moderate to severe pain, we mostly use like morphine is a choice because it is like cheap, available in the market.
Yeah. Thank you, Kusum. You are in which aims?
Sir, I am a PhD scholar in AIMS Rishikesh.
Okay, thank you. So what are the other opioids in addition to morphine in the third step? Anybody? We have morphine in addition to that.
Please put your answers in the chat box.
Are there any answers?
No, sir, not yet.
Okay. So as nurses,
Fentanyl.
yeah, fentanyl. That's correct.
Any other answers?
Good afternoon, sir.
Yeah.
Tramadol also is a weak opioid.
Tramadol is weak opioid. Now we are talking about the third step in which we
Yes,
have
sir.
strong opioids.
Yes, sir.
So 2 strong opioids, one is morphine and the other one is fentanyl. We have one
Sir.
more available in India. Which is that?
Sir,
Okay.
naproxen.
Naproxen is NSAID. not an opioid. It's methadone. Methadone. Okay. So let me show you the picture of this gentleman. When you see this picture, what is it struck your mind by seeing this photo? Question, please unmute and speak.
So, sorry. Patient is looking like he is in severe pain, unable to do his activity and his like daily living. Everything is disturbed.
Yeah. So from this picture itself, we can understand that this patient is in very severe pain. Okay. So this is the description of this patient. He is a 56-year-old man who knows to have carcinoma of the larynx. And he has undergone the curative therapies like radiotherapy, and you can also see he has a tracheostomy. But now the main problem is the severe pain, which is 10 by 10. His course is 10 by 10, so it is the worst imaginable pain. And he described it as a sharp pain without any radiation. It's all around the neck, and he was unable to sleep because of this pain for the last 2 weeks. So if you see a patient like this, how will you manage a patient with severe pain? How you manage?
Morphine is the answer, sir.
Yeah, morphine can be given. Okay. So which route will you administer morphine?
It's coming in oral dose, sir, mostly. Na?
Okay.
Oral.
Suppose any of you are in severe pain, how fast you want pain relief? All of you have 10 by 10 pain. How fast you want pain relief? Immediately? So what should be done if you need immediate pain relief or faster pain relief? So we can give injection, isn't it? So that it will act fast. So we can give injection morphine. Okay. After the injection morphine, the patient is like this within an hour. And how we administer injection morphine is known as intravenous morphine titration or intravenous morphine trial. So how do you do an intravenous morphine trial? So what is the strength of an ampule of morphine in your state?
Sir,
Yeah.
sir, it comes as an ampule of 15 milligram per ml, and then we dilute it to make it 10 ml.
Yeah.
I mean, 1 is to 1.5. Then we give 2 ml. That means 3 milligram we can start with, and we can give up to. It can be given according to the pain, and 6 hourly or 4 hourly it can be administered to the patient, and we have to see the respiratory, look for any respiratory depression.
Okay, thank you, Jaya. You have given a glimpse of what will happen in morphine trial. So let's see. So in Kerala also we have 15 milligram in 1 ml. So as she told, we will dilute the 1 ml of morphine with 9 ml of normal saline. So total 10 ml contains 15 milligram of morphine. And from this, that is 1 ml. 1 ml equals 1.5 milligram. Injection morphine 1.5 milligram is given at 10 minutes interval. But do you expect any immediate side effect by administering injection morphine? Anybody? Have you seen any such side effects by administering tramadol or any other opioid? What is the immediate side effect?
Sir, we should check respiratory rate of our patient because sometimes if overdose can be given to, there is
Yeah.
a chances for respiratory.
Okay, Kusum is concerned about respiratory depression. Anybody else? What would be the immediate side effect?
Vomiting.
Yeah. So that's the most common problem that can occur with the first dose of an opioid. So you have to give a injection metoclopramide 10 milligram IV before giving the or starting the morphine trial. So injection metoclopramide 10 milligram IV start, followed by injection morphine 1.5 milligram at every 10 minutes interval. And what is the endpoint of morphine trial or morphine titration? How long would you continue to give morphine injection? Anybody?
Jaya?
It can be, in palliation, if we can continue till the patient gets relief.
Okay. So I will change it a little bit. The endpoint is either the patient has satisfactory pain relief or the patient developed sleepiness. Okay. So that means sometimes the patient may not have good pain relief, but they will become drowsy. That means the pain is not so much opioid responsive. That's why the patient is becoming drowsy. In such situation, patient may not have pain relief, but you have to stop because the patient is drowsy. But many patients can have good pain relief, and then you can stop. So endpoint is either the patient has satisfactory pain relief or the patient develops sleepiness, whichever be the first. Okay. So for IV morphine trial, you can make a chart like this, which includes time, pulse rate, respiratory rate, blood pressure, pain score. Is the patient drowsy or not? What is the dose of morphine you have given? So you will monitor all the vitals. Suppose this patient came at 10 o'clock. You will take all the vitals. You will ask the pain score of the patient. It is 10 by 10. So you decide that, okay, this patient needs morphine trial. And you are looking at the patient and asking, are you drowsy? No, I am not drowsy. You are giving the first dose injection morphine 1.5. So before this, you will give injection metoclopramide. Then you will wait for 10 minutes. At 10:10, you will ask the patient about the pain score. It's 7 now. You will check all other vitals. You will also look for for drowsiness. Patient is not drowsy. You will give again 1.5 milligram. And you can see at 10:30, this patient pain score came down to 1. And the patient is not drowsy. But patient pain score came down to 1. That means patient has satisfactory pain relief. So this is an indication to stop the morphine trial. Okay. So how many doses this patient received? 3 doses. Okay. So this patient received total 3 doses of 1.5 milligram of morphine. That is 4.5 milligram of IV morphine. And the patient has good pain relief. And you want to send the patient home. Is this a inpatient procedure or outpatient procedure?
Sir, IV trial is like a inpatient procedure. We have to admitted patient. We can go for trial.
Okay, I can't see who answered that.
Kushum, sir.
Kusum. Okay, Kusum. Kusum. Actually, you need not admit the patient. This can be done on an outpatient basis. So every day we conduct at least 2 or 3 IV morphine trials in our outpatient department. So no need to admit the patient. And after this, you can send the patient home after converting the injection into oral morphine tablet. So how will you convert injection morphine to oral morphine? This patient received 4.5 milligram of total IV morphine. So how much oral morphine are you going to give for this patient? And how frequently?
Sir, is it 5 mg TDS?
Not really. How did you reach 5 mg?
In most of our patient, they receive 5 mg TDS. We start with that.
Okay, okay.
Sir,
Anybody
there
else?
is there is a formula like exactly I'm not remembering like IV is equal to 3 times of that means oral dose like 4.5 for this patient total. So
Hmm.
it will be 3 times like it will be around 13 mg or 14 mg around. So we can divide in BD doses or TDS.
Who was that?
Sir.
Kusum, okay, okay. Kusum, what you told is right, but what we have to understand is if a patient is on continuous IV morphine, at least for a day, then the conversion factor that you have told, that is multiplied by 3, would be applicable. Because morphine will take about 24 hours to have the sustained blood level. But here, the patient has received IV morphine only once or thrice, and it's only maybe at the maximum 1 hour. So the conversion factor of 3 is not applicable here. Actually, there is a study conducted by our chairman, Dr. M. R. Rajagopal, and his team at Calicut, where they converted the IV morphine to the same oral dose. So 4.5 milligram IV morphine means you can convert the patient to 4.5 milligram oral morphine. Kusum, did you understand?
Yes, sir.
Do you understand the difference? If the
Yes,
patient
sir.
was on continuous IV morphine for a day, then we would have multiplied by 3. But here,
Yes, sir.
the patient has received IV morphine only for a few minutes or at the maximum 1 hour. So that the conversion factor 3 is not applicable here. We will convert the IV morphine to oral morphine. So 4.5 milligram of IV morphine equivalent to 4.5 milligram of oral morphine. But from a practical point of view, we don't have 4.5 milligram of oral tablet or capsule. So then capsules 5 milligram may be available at some places, and 10 milligram oral morphine tablet is also available. So we can convert it into 5 milligram. And how frequently should we give morphine? What is the duration of action of oral morphine tablet?
4 hourly.
Yeah, 4 hourly. So it should be like this. Tab morphine for this patient would be tab morphine half when the patient wakes up, then at 10 a.m., then 2 p.m., 6 p.m., and at the bedtime, you will give double dose. In addition, you can also give SOS dose, which is the regular dose, that is 5 milligram. Okay. So for easier understanding, you can say 6 a.m., 10 a.m., 2 p.m., 6 p.m., and 10 p.m. But you can see the 6 a.m. and 10 p.m. doses are relaxed. Many of the patients who are in pain may not wake up at 6 a.m. They will be sleeping. So you need not waken them up. So give the first dose of morphine when the patient wakes up. And the 10 p.m. dose when the patient wants to go to bed. Maybe at 9 p.m. you can give the double dose. So this is how usually the oral morphine is administered. And you can also give an SOS dose. And if morphine injection is not available, you can also give an oral morphine trial. So I think it was Kusum who told that they use 5 milligram oral tablets. So if the patient has not taken any opioid, then you can start the patient on 5 milligram of morphine every 4 hourly and SOS dose. But if the patient is already on tramadol or codeine or dextropropoxyphen, and if the patient doesn't have pain relief, you can start him on 10 milligram morphine every 4 hourly and SOS. So now we will move on to breakout rooms where we will split up into 5 groups, and each group has to discuss about one patient story. We will share 5 patient stories, but the group 1 has to discuss only first patient story, group 2 only second patient story. Likewise, Only one patient story you need to discuss. So it's over to Sri Priya.
Thank you, sir. Just some basic ground rules before launching the breakout rooms. First, once you receive an intimation on your screen to enter the breakout room, kindly accept the same and join the room. Once all participants have joined their rooms, please select a leader. So after the discussions are over, the leader has to summarize the points and when we return to the main session. Hope we are clear. Sunil sir, kindly confirm how much time we need to. Sunil sir, you are muted.
At 3:30, we can close the breakout rooms.
So I put it as 9.
Yeah.
So the rooms are opening now. Kindly accept the invitation you receive on your screens and enter the rooms. The stories will be shared in the chat box in each room.
To discuss with my team. I'm not sure what other things were discussed.
Okay. But you can tell whatever you have already typed it. Okay.
Okay, I was thinking that since the patient is taking 4 milligrams 4 hourly and breakthrough doses by the end of the day, I would add all the milligrams, total milligrams taken in the whole day, then redivide by 4. So 4 milligrams 4 hourly for 6 a.m., 10 a.m., 2 p.m. and 6 p.m. would give us 20 milligrams, and then 10 p.m. double dose would give me 30 milligrams of the normal dose. Then the 4 breakthrough doses, we usually use the day dose, not the double dose. So that means the 4 breakthrough doses would be 4 times the 5 milligrams we give during the day, giving us another 20, making it a total of
Okay, Antonia. So,
I was trying to add the total dose for the whole day so that I divide it again to give a new dose, but I've got up somewhere.
Yeah, it's okay. This patient is already on 5 milligram 4 hourly and SOS, and this patient now requires 4 SOS dose. That means the previous dose is not enough. That's why this patient requires 4 SOS dose. So that means, as Antonia told, you have to add up all the doses. Okay. Or in other ways, you can decide that you need to increase the dose of morphine. Okay. So what is the indication to increase the dose of morphine? The indication is if the patient is taking 2 or more SOS dose. PRN is same as SOS dose. Okay. When the patient is taking 2 or more SOS doses, you have to increase the dose of morphine by 30 to 50%. Okay. So this patient is taking 4 SOS dose. That means we have to increase the dose by 30 to 50%. So if you add all the doses, 5 milligram 4 hourly, that means patient is taking 6 times, that is 30 milligram. And you add another 20 milligram because 4 SOS dose. So it is total 50 milligram. So 50 milligram, it will be very difficult for you to give because of the availability of the strength of tablet. So from 5 to if you increase 50% of 5 milligram, that will be 7.5 milligram. But then sometime it might be impractical to make it 7.5. So in case of 5 milligram, you can also increase it to 10 milligram, which is a 100% increase, but it should be okay for this patient because 10 milligram for hourly means it is only 60 milligram if you add up all the doses. So 7.5 to 10 milligram for hourly with SOS doses is okay for this patient. And how frequently would you give SOS dose of oral morphine? Anybody?
We
Good
give
point.
it when the patient asks for it, when pain comes back and it is before the next dose, we can give SOS before the next dose.
Yeah, what should be the minimum interval between 2 doses of morphine, oral morphine?
It's
I
4
think
hours.
once is enough.
4 hours is the normal dose which we administer. But suppose the patient has taken morphine at 6 a.m. and the patient says, I have pain by 6:30 a.m. What would you do? So we have to understand a little bit about the pharmacology of morphine. Okay, so this is the poppy plant, which is legally cultivated in India only in 3 states, UP, MP, and Rajasthan. And you can see the farmers are making cuts on the seed-like thing, which is known as pod. And the sap coming out from the pod is dried in sunlight. And they will transport it into government opium and alkaloid factories where they will make morphine powder out of it. Okay. And what happens when you take morphine orally? It is absorbed from the upper small intestine. And morphine is water soluble. So because of that property, it has a slow onset of action, but longer duration of action. It has a duration of action of 4 hours, but it will take some time to act. So these are a few important points which you need to understand. Morphine should not be given sublingually, buccally, or gingivally because it is not absorbed or the absorption is very, very slow through these routes. So it is not advisable to administer morphine through sublingual, buccal, or gingival routes. And if you powder the morphine, it also has a bitter taste. So remember to sweeten it with some juice or something if you powder the tablet and give it to patients. And after absorption, what happens? So you swallowed the morphine tablet, it will go into the gastrointestinal tract. From the second part of duodenum, it is absorbed into the blood vessels of the intestine. And then from there, it will go into the portal vein. And from portal vein, it will go into the liver where metabolism of morphine takes place. And the metabolites are liberated into the systemic circulation. Okay, so the metabolism of morphine takes place in the liver, and metabolism converts morphine into 2 main metabolites, which is known as morphine 3 glucuronide and morphine 6 glucuronide. In short, we call it as M3G and M6G. And you can see the M6G is formed in only in 5 to 10%. Actually, that is the component which will give you the pain relief. M3G doesn't have much action in our body. So the component which will give you pain relief is formed in less. Okay. So how frequently would you give SOS dose of morphine? So you have to understand that morphine has to be swallowed. It has to be absorbed from the upper small intestine, then go into the liver where metabolism takes place. So this process will take some time. So the action of morphine will start by 30 minutes, but the peak action, peak analgesic effect will be by 1 hour. So it is better to wait for 1 hour before you administer the next dose of oral morphine. Okay, so 1 hour is the answer. This was the second story. I think Kusum and team discussed this. Kusum?
Yes, sir. Yes, sir. Mr. X pain was stabilized with 10 mg morphine 4 hourly, but the patient is saying it's very frequently. So he would like to willing to take it, but with less frequency. So like with 10 mg 4 hourly total dose will be 10 like 6 a.m. 10 mg, 10 p.m. 10 mg, 2 p.m. 10, and then 6 p.m. 10, and night dose is double, like 20 mg. So total dose of for this patient is like 60 mg of morphine. So like we can change the 4 hourly regime to 6 hourly also, because patient is like said he want to take less. So we can change the regime to 6 hourly, like 12.5 mg at 6 a.m., 12.5 at 12 noon, 12.5 at 6 p.m. and at night we can do the doubling like 25 mg.
Okay. Okay. Do we have any other answers? Let us see. So Kusum has talked about one of the practical thing. But the problem with that would be sometimes the patient may be more drowsy because 10 milligram was the morphine which was required for the patient for good pain relief. When you administer more each time, then there is a chance that patient may become drowsy. But what else can we do? We can actually use sustained release morphine. Okay. So what is the what is the advantage with the sustained release morphine? The duration of action is 12 hours.
12 hours.
Okay. So the patient need to take morphine only twice, once in the morning and once at night. So this patient is taking 10 milligram 6 hourly. So as Kusum told, total dose is 60 milligram. So you can convert it into tab morphine sustained release 30 milligram BD. Okay. So this is what you can do from a practical point of view. The only problem is the cost will be higher than that of fast acting morphine. And these are the preparations of morphine available: aqueous solution or syrup, tablets, two types. One is immediate release or fast acting tablet, which duration of action is 4 hours, and controlled release tablet, it is 12 hours. Controlled release or sustained release, both are same. And injection is also available. And this was the story number 3. So can the group 3 come up with what they have discussed?
Hello.
Yeah.
Yeah, Vishwajit.
Hello.
Yes, yes.
Yes. Hello. Myself Bishojit. We got the story. Story 3. That is Mr. S was on 10 mg morphine 4th hourly for the past 6 months. He was brought to you with excessive drowsiness. On examination, it is found that he has a serum creatinine of 5 mg per dl. What will do anything for morphine doses? So we discussed few things about the story with group members. So we think that we can reduce the morphine doses because patient already having drowsiness, excessive drowsiness. So we can reduce the morphine dose, and we can regularly check the IU chart, and we can give the fluid, and regularly we can do the blood investigation for create level.
Anybody else?
Hello.
Yeah.
Sir. Sir, only 4 or 5 things.
Yeah.
5 things we discussed about the story. That I already mentioned. That
Okay.
first one is we can reduce the morphine doses because patient already having excessive drowsiness.
Okay.
And we can do the regular check the IU chart, and we can give the fluid, and we can do regularly check the create level.
Yeah. Okay, thank you, Viswajit and team.
Thank you.
We have this patient who came to you with excessive drowsiness, and his serum creatinine is 5 milligrams per deciliter. What is the importance of serum creatinine here? So that's what you have to understand. Morphine is actually excreted from the body by glomerular filtration through urine. So what happens if there is renal failure? The morphine and its metabolites accumulate in the blood, so that it is not going out. It is whatever you are giving, it is there in the body. So it will accumulate, and that will lead to drowsiness and more other symptoms. So in this patient, what you have to do is, first of all, you have to stop the morphine. Maybe 1 or 2 doses you need not administer till the patient becomes alert. And then once the patient becomes alert, then you have to reduce the dose of morphine. And also, instead of 4 hourly, you may administer it 8 hourly or 6 hourly or 12 hourly. So this is some situation where you use morphine with 6 hourly or 8 hourly or 12 hourly doses. Okay. Or otherwise, you can use renally safe opioids like methadone or fentanyl. So story number 4. Group leader, please.
Hello.
Yeah.
Hello. Good afternoon, sir. My name is Jijo.
Yeah.
Yeah, sir. I got the story for number 4. Mr. X
Yeah.
was sent home and he is taking tab morphine 5 mg 8 hourly. After 2 months, he was unable to swallow anything, including morphine. What would you do now for pain relief?
Yeah.
Actually, sir, that patient was gone home. So I think we will call back the patient because he had the unable to swallow the patient. That the ex-patient is already have the oral cavity related disease condition. So assess the condition, then we want to continue this dose and assess the pain, patient respiratory distress, nausea, constipation, that all things. We assess first and we can go for a Riles tube insertion if it possible. Then we can continue the same dose. If it not possible, we can go for IV in a hospital setup. Hospital setup. So another first thing is that we can assess a Riles tube and continue the dose and assess how it's going, means the pain reducing or pain is getting better or not. Another thing, maybe patient is having some oral cavity problems also, ulcers or something like that. That is also reason why he is not taking. Yeah, sir.
Okay, thank you, Jijo. Here, patient is unable to take anything orally. What Jijo told is right. If we can put a Riles tube, we can try for that. If in the hospital, we can try for injection. Jaya, do you want to comment on?
Yes, sir. I'm in this group only.
Yeah.
Maybe we can introduce fentanyl patch or buprenorphine patch along with this.
Okay.
I mean, we can do, and we have to see for the BP, and BP charting has to be done, and then we have to look for the constipation, nausea, and vomiting related to the opioid things.
The problem, we will come to that when we discuss the next story. Okay. Suppose this patient is at home. What are you going to do? Will you be able to give injection morphine? No, it will not be possible.
No.
And Riles tube is also you are unable to put because of the oral pathology. So what are you going to do at home? That's what we need to discuss. So what are the routes through which you can administer morphine? You can give intravenously or subcutaneously. Orally you can give. And which are the other routes? Any other routes? Okay, you can administer morphine parectally. So if you administer morphine parectally, I told you morphine is water soluble. So you have to administer the dose which you were giving per oral. That same dose need to be given parenterally. The effect and pain relief will be same. The duration of action will be same. So this patient was taking 5 milligram 8 hourly. So you have to actually take 5 milligram of oral morphine tablet, then add 2 drops of water, make it a paste, and then rub it in the anal canal so that it will be absorbed. The results will be the same. Okay. In addition to this, you can also administer morphine epidurally and intrathecally. So, okay, so we will give 5 milligram morphine 8 hourly parenterally. The tablet used will be fast acting tablet. It is not sustained release tablet. It is the fast acting tablet. If you crush the sustained release tablet, its property will be lost. So it should not be used. Okay. So story number 5. Group leader, please.
Yes, yes, sir. Actually,
Yeah,
hello.
Rajesh, please.
Yeah, the story that Mrs. K, 55 years old lady with carcinoma of the colon as abdominal pain, continues on 10 mg morphine quarterly 4 hours, and she does not require any SOS dose of morphine. A doctor has asked them to replace morphine with 25 microgram fentanyl patch. Next day, patient report to you telling that they replace the fentanyl patch after 5 hours as she had no pain relief. What will you do? Either we can start with an additional dose of this morphine orally, or we go for another route, because we have tried the oral route as well as the patch also. So if it's possible, we can give her with an injection of morphine. Alternative dose we can try with that.
Okay. Anybody else want to comment on this? So this patient was put on a fentanyl patch, 25 microgram, and the patient replaced the fentanyl patch after 5 hours because there were no pain relief. So these are some practical problems which usually occurs. This is actually a patient who came to us and told this story. That's why I put this story here.
Okay.
There are a few points which you have to understand regarding fentanyl patch. So how does the fentanyl patch act? Once you apply the fentanyl patch, it forms a subcutaneous tissue storage. Okay. So, and from this subcutaneous tissue storage, constant amount of fentanyl will be released into the systemic circulation. But to have this subcutaneous tissue storage, it will take about 8 to 12 hours. Okay. So the action of fentanyl patch will start only after 8 to 12 hours. But this patient removed the fentanyl patch after 5 hours because there were no pain relief. And the person who advised the fentanyl patch didn't give much information about fentanyl patch. That's why this occurred. Otherwise, they would have continued with the fentanyl patch. So till 8 to 12 hours, you have to wait. But until this 8 to 12 hours, you have to continue the opioid which the patient was using previously. So in this case, the patient need to use the morphine till 8 to 12 hours after application of fentanyl. Okay. So the duration of action is, as all of you know, it is 3 days. The fever and skin condition, that means if there is any break in the skin or abrasions, you should not shave the area because it will produce abrasion. So you need to clip the hairs before applying the patch. Don't shave the area. So temperature and skin condition will affect the absorption of fentanyl. And it should not be used in a patient who has unstable pain. So if a patient has severe pain, don't use fentanyl patch. You have to first control the pain with morphine. And once you find out the dose which is required for pain relief, then you can convert it into fentanyl patch. because fentanyl patch will liberate only constant amount of fentanyl into the circulation. You will not be able to give an SOS dose of fentanyl patch. Okay, so don't apply fentanyl patch for patients who have unstable pain or acute pain. Morphine is the gold standard then. So fentanyl is available in 3 preparations. Injections are available. Transdermal fentanyl patch is another, which we have discussed. Then oral transmucosal fentanyl citrate, which is actually a lollipop-like things, and you need to rub it over the buccal mucosa, which will give instantaneous pain relief. And actually, fentanyl is more potent than morphine. If you that is 100 times more potent than morphine. That means if you give 100 milligram of morphine to a patient, you need to give only 1 milligram of fentanyl. That is what potency 100 times more potent means. And for patients who are taking 60 milligram of oral morphine per day, that is 10 milligram 4 hourly, you need to give 25 microgram per hour fentanyl patch. And if it is 30 milligram oral morphine per day, it will be 12.5. The previous patient was taking only 15 milligram, where Jaya suggested fentanyl patch, which we cannot convert because 6 point, we cannot cut the patch into 2. So a fentanyl patch is not practical in that patient. Okay, so we will move on to another patient. This is a 70-year-old man with carcinoma of the lung and is complaining of throbbing pain on right front of chest, continuous 5/10. He is a non-epileptic and is on phenytoin 100 milligram BD. How will you manage his pain? Anybody?
So weak opioids.
Yeah, which one would you suggest? Which one would you suggest?
Like tramadol, we can start.
Okay, thank you, Kusum. This patient has a pain score of, Taufik, please unmute and speak. Please unmute, you are muted. Can you unmute yourself, Taufik? Okay, I think there is some problem. So this patient has a pain score of 5/10. That means this patient has a moderate pain. So you can actually start this patient on second step of opioid. Second step of WHO analgesic ladder. The first step of WHO analgesic ladder is for mild pain. Second step is for moderate pain, and third step is for severe pain. So this patient has a pain score of 5, which means moderate pain. So you can start with opioids for mild to moderate pain. As Kosam told, tramadol, tapentadol, dextropropoxamine, or codeine. But what we have to understand is, anybody want to comment on the choice of tramadol in this patient? Tramadol has a problem. It will reduce the seizure threshold. Okay. So this patient is already a non-epileptic. So giving tramadol can actually precipitate seizure in this patient. So that is something which you have to be careful. And patients who have brain metastasis, those are also patients who have less seizure threshold. So giving tramadol in those patients can precipitate seizure, and don't give injection tramadol fast IV push. It can also precipitate seizure. Okay, so tramadol, if possible, avoid in this patient, and maybe you can give a low dose morphine, maybe 2.5 milligram. Okay. This is another patient. Mr. P is on tab morphine 50 milligram 4 hourly. She attends your clinic with severe pain. You have injection pentazocine and oral morphine tablet. How will you manage? Anybody?
So we can increase the dose of oral morphine.
Why don't you use injection pentazocine? Because we need to give fast pain relief. Anybody else? Okay, let's see. You have to, we have to again go to pharmacology. How does the opioid act? It acts on opioid receptors. Okay, so there are mainly 3 opioid receptors: mu, kappa, and delta. And the opioids combines with these opioid receptors to produce physiological changes, and it will produce analgesia and other effects. So opioids are divided into 3, which are known as agonist, antagonist, and agonist. So agonist means it is an opioid which combines with opioid receptors to produce pain relief. So which are those? Can you name some of the agonists? All the opioids which we know: tramadol, codeine, morphine, fentanyl, methadone, all are agonists. What is an antagonist? It is the antidote for opioid. What is the antidote for opioid?
Naloxone.
Yeah, naloxone and naltrexone. So that means they will reverse the effect of opioids. Suppose I give naloxone to you, it will not have any action in your body because you are not taking opioids. But if naloxone is given to a patient who is taking morphine, that action will be reversed. The patient will have pain. Okay, so that is agonist. And the third group, agonist and agonist, means on some receptors it will act as agonist, and at some receptors it will act as on opposite direction. Okay, antagonist. So that is agonist and agonist. So this is the main difference between agonist and antagonist. You can look at this graph and see the one on left side, with the graph is for agonist. And on the x-axis, it is the dose of the opioid, and on the y-axis, it is the pain relief. So suppose I give this much dose of agonist, you will have pain relief up to this point. And when I increase the dose, you will have more pain relief. And when I increase the dose till this point, okay, you will get complete pain relief. So as the dose of agonist is increased, you will get corresponding pain relief. 100% is pain relief theoretically. But in case of agonist and agonist, please look at the graph. What happens after a certain dose? You can see the dose after which up to this point you will get pain relief. But after that, even if you increase the dose, you can see the curve is plateauing, flattens. So after this dose, even if you increase the dose of agonist and agonist, it will not give pain relief. This is known as ceiling effect for analgesia. Ceiling, there is a ceiling. So agonist and agonist group have a ceiling effect for analgesia, whereas agonist group doesn't have ceiling effect for analgesia. So that is the main difference between these two groups. And pentazocine, pentazocine is actually it acts on 2 receptors. It acts as an agonist at kappa receptor, but it is an antagonist at mu. But morphine is a mu agonist. So we know that morphine is a strong analgesic which will give you pain relief. Morphine is a mu agonist, but pentazocine is a antagonist at mu. Okay, but agonist at kappa. You have to understand that the opioids which are acting on mu receptors are the potent opioids. So if you give pentazocine to a patient who is already taking morphine, what happens is the pentazocine will replace the morphine from mu agonist. Okay, and pentazocine will attach to mu, which will now act as antagonist. Now morphine is out from the mu receptor, and the pain relief is now due to kappa receptors. So which will not give much pain relief, and actually the pain can worsen. So if you give mixed agonist antagonist like buprenorphine or pentazocine, to a patient who is already on strong opioids like morphine, there is a chance that there will be more pain. So just understand this. Don't give agonist and agonist to a patient who is already on a mu agonist. So now we'll move on to side effects. What are side effects? Side effects means these are the adverse effect with therapeutic doses. So what are the usual side effects? Constipation, nausea, vomiting, sleepiness and tiredness, itching, dry mouth, urinary hesitancy. The first three are major side effect and the last three are minor side effects. Constipation occurs in almost 95% of patients. That means almost all patients will have constipation on opioids. So you have to give a laxative along with opioid whenever you prescribe. So don't miss it. But the laxative, you have to give stimulant laxative. Okay. The example of stimulant laxative is bisacodyl or sodium picosulfate or senna. Don't give the powder like laxative, which are usually prescribed for patients. It will increase the constipation. Okay. So you have to continue the laxative as long as the patient is on opioid. This is what you have to understand. And nausea and vomiting, it occurs in almost 30% of patients, but it will occur, it will be there only for the first few days, maybe 3 to 5 days. After that, it will subside by itself. But for the first 3 to 5 days, you have to give an antiemetic, and the preferred antiemetic is haloperidol, metoclopramide, or domperidone. And the nausea and vomiting is due to action on chemoreceptor trigger zone, which is an area in the brain. Okay. And sleepiness and tiredness also occurs in only 1/3 of the patients for the first few days. It will disappear in maximum in 1 week. So you need not do anything for this. Now we were talking about side effects. Now we will move on to toxic effects. What are toxic effects? Toxic effects means when you administer higher than the required dose, it will cause some adverse effects which are known as toxic effect. So these are the signs and symptoms of toxic effects. The patient can have delirium. Delirium means irrelevant talk. Myoclonus, frequent myoclonic jerks. And patient will be having undue drowsiness. You will not be able to wake up the patient. Okay, so that is the type of drowsiness which will occur with toxic effect. And patient can have pinpoint pupil. And this is what you were talking about in the when I asked about IV morphine. Opioids, is it going to produce respiratory depression? Actually, there is evidence that oral morphine is not usual to cause respiratory depression. Okay. For the last 17, 18 years of my palliative care experience, I haven't seen any patients with respiratory depression. So it is very safe to use. I might have prescribed morphine for oral morphine for 10,000s of patients. I haven't seen even a single case. And another worry would be this addiction, opioids causing addiction. So there is a difference between, there are two types of dependence. One is physical dependence and the other one is psychological dependence. If you stop atenolol, what will happen to that patient? Suddenly you are stopping atenolol for a patient who was taking for a long time, for the last 4 years. What will happen? Anybody?
Probably the blood pressure will go up again.
Yeah. Patient can have tachycardia, sweating. So does that mean this patient is addicted, or patient has psychological dependence to atenolol?
Psychological.
No, it
I
is
don't
not
think so.
psychological dependence. It is physical dependence. Okay. Actually, psychological dependence is addiction, whereas physical dependence is something which is caused by regular, if the patient is taking some substance or medication regularly. So when you stop that medication, suddenly the body will react, which is known as withdrawal symptom. It is not psychological dependence or addiction. So in case of morphine also or opioid also, if you give it for a long time, don't stop it abruptly. You have to taper the dose and then only stop opioid. So what is addiction? I will give you an example. Many of you might be having coffee in the morning. Once in the morning, coffee powder and sugar is not available. Will you have any manifestation? What will you feel?
Maybe headache or something, sir.
Headache, yawning, irritation. Does that mean you are addicted? Do you have psychological dependence?
No, sir. Physical dependence. Actually.
It is physical dependence. But if you break into the neighbor's house where sugar and coffee powder has kept, that means you have addiction. So that's the difference between physical dependence and psychological dependence. But what you have to understand is opioids can cause psychological dependence in a minority of patients, especially patients who are having non-cancer pain. Okay. I'm not, I will give this one slide more. So this is something which you have to understand. Please look at the price of opioids between morphine, tramadol, fentanyl patch, and methadone. Morphine is very cheap and it is comparable to methadone. But look at the cost of tramadol and fentanyl patch. So this is something you have to understand. Whenever somebody prescribes fentanyl patch for a patient who is very poor, I don't know how they are going to make it. Okay, so I will stop here. And Shiva, it's over to you.
Thank you, sir, for the excellent presentation. Anybody have any doubts? So if you have any doubts, please put the questions in the chat box. In the meantime, we can go to the case presentation. Can we move on to the case presentation, sir? Sanu Ashwini,
Yes.
will be presenting a patient story. So welcome and over to you.
Okay. Let's start with the case presentation. It's me, Anu Ashwini Kisku. I am working here as a nursing team supervisor in the Doctors Without Borders India. It is present in the Patna. One patient, male patient, 45 years old. He came to our facility and we diagnosed him with a PLHA, that is person living with HIV/AIDS. Second, tuberculosis meningitis. Third, hydrocephalus. Fourth, hyponatremia. And fifth is COVID-19 positive. Present complaint was he was admitted on 8th Feb 2022 with the chief complaints of intermittent fever from last 6 months, altered behavior from last 3 days, drowsy, hiccups from last 3 days, and loose stool from 1 week. History of illness. When he came to our facility, his GCS was very poor, that is E2, V2, and M3. That is total score is 7. Known case of HIV positive since 16th November 2021, but he never started ART, no allergy to any drugs, no cardiovascular risk, poor adherence of drugs because he was not taking the medicines of, he was not taking ART treatment. Then date of diagnosis of HIV was 16/11/2021, but never started the ART medicine. When he came to our facility, after that we had started the tablet TLD, that is T stand for tenofovir, L lamivudine, and D dolutegravir. And after that we have changed to ALD because due to some kidney function test was deranged and creatinine level was increased. Because of that we have switched to ALD, that is our A stands for avacavir, for L lamivudine, and D dolutegravir, and additional DTG we used to give him. And his CD4 count was 39. Patient was on ATT. 4 FDC we used to give due to CSF MTB gene expert detected. On examination, we'll see the vital sign. Blood pressure was 164/70, that is hypertension. Pulse was 122 beats per minute, respiration 28 per minute, temperature was 101.8 degree Fahrenheit, and saturation was 98, and blood glucose level was 120 mg per dl. He was hypertensive and tachycardia, tachypnea, and have temperature also. And physical general examination, skin, no any defect on mouth, some thrust was present, JVP was normal, DVT not detected, cardiovascular system pulse regular, auscultation S1, S2 sound heard, respiratory bilateral airway present, chest movement was normal, abdomen, there was no tenderness, no splenomegaly, no hepatomegaly. On the side of CNS, GCS was poor, E2, V2, M3, neck rigidity was present, pupil, right pupil was little sluggish, and pain assessment scale, we had scored 8 out of 10. On the basis of treatment and significant investigation, we have done the routine investigation here, that was CD4 count was 39, sputum MTV gene export was not detected, HB was 12.5 gram per dl, platelet was 63,000, urea was 50.2 mg per dl, creatinine was 2.8, sodium 126, potassium 3.9, SGOT 123, SGPT 122.8. And CSF, we had done the LP lumbar puncture also here, and we have sent the test for CSF MTB gene expert. It was detected very low, rifampicin resistance not detected. And we have done the MRI in that infarct with meningitis. We have done the treatment, hyponatremia treatment we have done here to correct the hyponatremia, given the injection 3% NaCl, and ART started tablet TLD. For tuberculosis meningitis, we had started ATT, and with high dose of steroids. And for nutrition, we had given Easy Paste 2 sachets per day, and also treated the antihypertensive drug we had given. For analgesic, initially patient was on injection paracetamol, but after that also patient will have no improvement, so we started injection morphine, and antiplatelet treatment also we started. Next slide. Medication for tuberculosis meningitis, we had given 4 FDC, that means fixed dose combined. In that there will be isoniazid, rifampicin, pyrazinamide, and ethambutol. And second, injection dexamethasone 36 mg we had started, it is steroids, and tablet amlodipine 5 mg OD we have started for antihypertensive. And then tablet cotrimoxazole 480 mg OD, we used to give PCP prophylaxis to all the PLHA patient, and tablet aspirin 300 mg stat for 14 days, then 75 mg OD. This we had given for infarcts. And injection metoclopramide 10 mg BD, we had given this to prevent the aspiration. And tablet lopramide 2 mg SOS we had given for the treatment of loose stool. Tablet TLD and DTG changed to ALD. I said before that patient have, when we admitted the patient, that time creatinine level was normal, then we started TLD, and after his creatinine level goes to 2.8, after that we have switched to ALD and DTG. And injection hyoscine we had given for fluid management, NS and RL we had given, and for nutrition Easy Paste half sachet QID, and injection morphine 2.5 mg QID dose we had given. Psychosocial aspects. First, patient attendants were worried. His wife don't know about the disease condition and did not test yet. Patient is unconscious, so mainly focusing on the personal hygiene. Fourth, mental health status team focus on the adherence counseling and psychological counseling. Fifth, health promotion team to assign lay counselor to monitor the case and update about the patient condition by telephonic/home visit. Health education related to the palliative care. Main concern was advanced HIV with COVID-19 positive, chest and limb physiotherapy, low platelet count, COVID-19 positive, persistent hyponatremia, and semi-conscious and bedridden. Yeah, summary. As I told, a patient came with a 45 years old admitted on our facility on 8/22 with chief complaints of intermittent fever, loose stool, hiccups, drowsy with GCS, score 07. He was diagnosed as HIV on 16/11/2021 and never took ART. Here we have done the routine investigation and see the parameters CD439, COVID-19 positive, low platelet count, hyponatremia, 126 mm OL per L, and all other investigation were normal. MRI brain source infarcts with meningitis. We had done the LP in that it was in CSF, it was MTB gene expert that MTB detected. That's why we have treated with ATT, and we had started here the ART medicines also. And for bacterial meningitis, we started antibiotics. Then monitoring the IO chart, where daily we are assessing the patient pain assessment scale, neurological assessment, weekly ESAS and PPS checklist. We are following patient condition. We had discussed in the MDT meeting and planned for palliative care and DNR. And we had now we sent to the patient to the home, but he is still in the semi-conscious stage. And we call him for the follow-up. Next slide. Discussion point for first one is COVID-19 is positive, health education to his wife about the disease condition. Third, how to take care of the patient at home.
Thank you, Anu. Anybody would need any more clarification regarding this patient story? If anyone need more clarification, please ask.
Do you work in a palliative care unit, Anu?
Yeah, it is a palliative care, not properly palliative care, because we are dealing with the HIV/AIDS patient, and after that we are treating them in a symptomatic treatment. We are used to done here, and we are deciding for the on the patient condition. We are deciding the palliative care.
Okay. So you have injection morphine and tab morphine, all those.
Yeah, we have injection. We are using a injection morphine only. We are using here for.
No tablet.
What did you say?
Tablet morphine is not available.
Yeah, tablet and injection we are using here.
Okay.
So I would like to know about why did you start injection morphine for this patient?
When patient was not improving, when the patient came, he was very much deteriorated and unconscious. And when he came, he was in an unconscious state. After that, previously we used to prefer injection paracetamol because he is having fever also. And for pain also, we started to treat him paracetamol. Then we SOS tramadol also we have given, but then also patient was not improving. There was a incompressible sound. After that, we decided to move into the morphine.
Okay. Thank you.
Okay. So Jaya.
Sir, I just want to say that if the patient is a case of tubercular meningitis and his GCS is 7/15, as it was told, so I'm not able to comprehend that why injection morphine was started, because then we cannot see about his neurological status, and that's also this is
Okay.
actually question.
Yeah. So from Anu's description, what I understand was that When the patient was brought, the patient was groaning and moaning. So they thought it is due to pain. And they tried to manage it with injection paracetamol, which didn't give any relief for that. Then they tried on tramadol, which also was not effective. But when they started the patient on injection morphine, the groaning and moaning disappeared. That's what I understand from Anu's description.
Yeah.
Thank you, sir.
So there are what you have to understand is that there are many patients who will not be able to communicate pain by verbally. So many patients, advanced cases of dementia is one of the example, and the children. So there are and even the disease affecting head and neck, carcinoma larynx. There are many patients who are unable to express the pain verbally. So there are some manifestations or behavioral changes that can occur to the patient. And one of the thing is groaning and moaning. And then there will be um, um, the facial expressions and how the hand and leg is kept. So there are mainly we have to assess the pain in patients in these type of patients is with behavioral changes or there's expressions. So this is very important. Patient in the new definition of pain by IASB, it says anything resembles pain should be considered as pain. Okay. So if somebody groans and moans and we are unable to find out any reason for that, we may have to think that it might be due to pain, and we may start with safely like paracetamol and move on to move on to uh, other steps of ladder. That's what can be done. And in patients with children, there are many pain scales to assess the pain. And in neonates, the one used is FLAC scale. FLAC means F means face. What is the facial expression? Leg means how leg is kept, and what is the activity of the patient. How is the cry of the patient? Is the mother able to console the patient? So these are FLAC, that is the short form of pain assessment, which is used for neonates. And in dementia, they use Painard scale. Painard, that is pain assessment in advanced dementia. Painard. So there are many scales which are used to measure pain in patients who are unable to express pain verbally. And this actually is a very first of all, I would like to thank Anu because this is a patient story where they are taking care of people who are living with HIV and AIDS, and patient also affected with COVID-19, which would be a very difficult situation. A few points which she brought out was what should be the instructions to the caregiver or wife to be yeah, what are the instructions to be given to the wife? Anybody? If a patient with HIV and AIDS come to your hospital and there is his wife with the patient, what are the instructions that you need to be given when they go home? And this patient is drowsy also. And the wife also don't know about the HIV status, isn't it, Anu?
because patient 5 was not that much educated. That's why she don't know about the disease condition also. And I think patient came with a drowsy state. I think his husband also not told him about the disease related to HIV, because when she came here, she was literally, she was shocked. She was not knowing about the HIV. Here we had counsel to her, and after that, little bit she now she know about the what is HIV, what is TB.
Okay. So what type of education or what are the instructions you usually give to the caregivers of this patient?
Here is a mental health counseling and health promotion team is working on it. And health promotion team, their work is to give all the details about the HIV, TB, how it's spreading, how we can use the precautions. That all things they all are giving the instruction to the patient attender. And mental health counseling, their work is to counsel them, to make them understand everything and about the patient condition, that they will make them ready to the attender that they have very less time, because it is incurable disease, so it will take so much of time also. By that we make them understand to the relatives.
Okay. So when the patient is bedridden, that is going to be more difficult for the caregiver because they need to handle all the excretions of the patient.
Yeah. We teach the patient attender how to give the riles to feeding, how to care of the catheter. That all things we used to teach them in the hospital. After practicing, we send them to home.
I think that is very good because sometimes we forget to say those things and they are very important. The nursing interventions, that's very good to hear that you teach them and they practice with you in the hospital before they go home. We always talk about the mental health, the I don't know what, and we don't say what we do as nurses. So I think that's very good, Anu, that you do that. And whenever you make a presentation, don't forget to say those things, because they are very important. I'm happy that you have said it.
Jijo John, do you want to say anything?
Hello?
Yes, Jijo.
Hello? Are you audible?
Yes, we can hear you.
Yeah. My name is Jijo. I am also working with the Anu. Yeah. Hello? It's clear?
Yes.
Yeah. So just 2-3 points I want to add with Anu's case. Okay, I know that case also. That patient was a sudden recently diagnosed cases. So that family and that caretakers are not aware that clinical conditions and everything. So that patient was a long length of stay around 1 month that we have treated that patient with this COVID and also this TB meningitis. 2-3 times that patient was admitted here. And also before every patient before discharging, we are assess them. We have some multidisciplinary team with a health promotion team, mental health team, and everything. So we are planning that how we can within the team we are discussing with the family members and the caretakers also how we can plan for this patient. It's affordable or not in the home setup, home care or not. And the patient relatives also is ready to take to home. That also we considering case. If patient party and family is not agreed to take to home, we are stay back and we are preparing and we are supporting. Full team is supporting with that patient. If then after that the patient and the relatives ready with going home or palliation, then only we are discharging that patient.
How many beds are there, Jijo?
Yes, sir.
How many beds are there?
Right now we have 45 beds, sir.
Okay. Is it full all the time?
Almost full, sir. We have some challenges, space issues, and also here we have the stigma and discrimination also here. So we are facing a lot of things, sir. Yeah, it's an independent and humanitarian organization. So maximum we are accommodating.
Yeah, Doctors Without Borders. I know.
Yes, sir. Yes, sir. Yes, sir. Okay. Okay. Thank you.
So, sir, I have read one question in the chat.
Yeah.
So what is the maximum dose of morphine?
So can anybody answer that? What is the maximum dose of morphine? So
Dose is like 0.025 to 0.5 mg per kg body weight.
yeah, but to answer that question directly, I would say that morphine doesn't have a maximum dose. Okay. So usually in a patient who, in an adult patient who is opioid naive, we will start with 5 milligram and 4 hourly and SOS. But I have gone up to 450 milligram 4 hourly in a patient, and I know that some of my colleagues have gone up to 650 milligram of morphine 4 hourly. And from literature, I understand that some patients are on thousands of milligrams of morphine. So there is no maximum dose of morphine. The dose required for a patient is the maximum that is required for that patient. Suppose a patient is on 5 milligram, that is the maximum dose required for that patient, because that will give pain relief. There will be another patient who need more than that. So we cannot generalize the maximum dose. There is no maximum dose. The dose required for the patient is what we need to consider.
Can we wind up the session, sir?
Yeah.
Time up. So we have learned many things today, many new things. So especially on morphine, usually doctors will be prescribing the drugs. So nurses or a pharmacist will be give the instructions how to take medications and all. So we have to give a proper instructions to the patient and the caregivers when we start morphine. That is very, very important. So always you have to try to communicate with the that patient or a caregivers with the simple language to avoid medical jargon. So that is very, very important. You have to make sure that try to understand them clearly how to take. So as we learned before, morphine has a 3 to 4 hours action. They should take every 4 hourly, and night time they should take the double dose. And the importance of rescue doses also. So in between they have pain, they have to take same dose as a rescue dose, but the the regular dose should not be missed. That is the another instructions. And the third one is the most the common side effect is constipation. They should take stimulant laxatives at night. So and the another thing is already we have learned about the side effects and the toxic effects. Side effects like nausea, vomiting, tiredness and sleepiness and all. So that will subside within few days. And you have to tell that patient and family to that also. And also if they develop toxic effect like delirium, myoclonus and drowsiness, they have to report the medical team as soon as possible. So and the last one is these medications should be specific to the prescribed patients and should not be used for any other person. So that is the instructions you have to clearly to the patient and the caregivers. If the another persons have developed a pain like maybe severe headache or back pain or something like that, so maybe the patients will suggest you, okay, you can take one morphine for your pain, something like that will happen. So you have to give a proper instructions for that also. Okay. Thank you. Thank you, sir, for the excellent presentation. And thank you, Anu, for presenting an excellent patient story. Thank you for making this session is very interactive. Thank you. We'll see you next week.
Thank you all, Dr. Sunil. Thank you so much. And everyone, please do fill up that feedback form. I have shared it with you. It's in the chat box, and you will share it in the WhatsApp group also. So please do it. And thank you all. We'll meet you on the next class. Bye.
Thank you.
And the another important message I want to convey with you all is today few of the participants were switch off your videos. I don't know how it is happened. So I already said this, it will not happen the next week. And those who are the switch off your video, please give an explanation to senior ma'am as soon as possible. Okay, thank you.